I am 1 in 40. Last year, I was diagnosed with stage 4 ovarian cancer caused by an inherited BRCA gene mutation. Today, after a dozen infusions of chemotherapy, major surgery, and one recurrence of the cancer, I'm still standing thanks to my support network, many of whom are here, several of whom are here today, and also to Massachusetts General Hospital. I'm currently in remission and on a PARP inhibitor. While there's still no cure for recurrent ovarian cancer, the PARP inhibitors have given my family some sorely needed hope for my future. 2 years ago, at the age of 45, I sought genetic counseling and screening on my friend Anne's urging. It's very important to note that Anne is not Jewish, she's not BRCA positive, nor is she a medical professional. Rather, she is a breast cancer survivor who learned of the 1 in 40 BRCA risk to Ashkenazi or Eastern European Jews like myself from her genetic counselor, Dana-Farber's Jill Stauffer. It's also important to note that I have a strong family history of breast cancer on my father's side. My father, Bob, pictured here and also here with us today. Thanks, Dad. Lost his mother to breast cancer when she was just 56 years old, 1 month after I was born. My father's sister was diagnosed with breast cancer twice. Here's the family tree that Jill Stauffer, my genetic counselor, prepared for my genetic counseling appointment 2 years ago. The genetic testing Jill ordered showed that I have a BRCA1 founder gene mutation, an actionable mutation that puts me at very high risk for breast and ovarian cancer. Dana-Farber advised me to have my fallopian tubes and ovaries removed, an oophorectomy, surgery that would have dramatically reduced my sky-high risk of ovarian cancer. But it was too late. Around the same time, and on my father's urging, I persuaded my former PCP to order an MRI of my back to determine the cause of severe unexplained back pain that I had been experiencing for weeks. That MRI revealed an incidental finding of what turned out to be ovarian cancer that had metastasized throughout my groin area and my torso and lymph nodes around my heart, my lungs, all the way up to my sentinel lymph node by my left collarbone. Talk about a double whammy. Less than 1 month after being diagnosed with a deleterious gene mutation, I was diagnosed with stage 4 cancer. While undergoing cancer treatment, I discovered that many Ashkenazi Jews are not aware that they have a 1 in 40 chance of being BRCA positive, and that these gene mutations put them at relatively high risk for cancers including male and female breast cancer, ovarian cancer, and prostate cancer. I founded 1 in 40 last year while undergoing treatment with a singular goal: to prevent the trauma that has happened to me and my family from happening to anyone else. It was entirely avoidable had either my father, Bob, or myself been referred by any of our PCPs over the years to a genetic counselor. 1 in 40 provides BRCA awareness, education, and emotional support. Thank you to all the social workers in the room. My mom is a social worker. She's here with us today, holding up the camera. She's a social worker who heads up 1 in 40's emotional support program. We have a team of wonderful volunteer therapists who help our constituents. Today, just 18 months after launching 1 in 40, we have mobilized hundreds of ambassadors across the country, reached more than 600 people through live events such as symposia, Shabbat talks at synagogues, and presentations for medical professionals at grand rounds. We've reached well over 10,000 people via social media and articles on 1 in 40 that have appeared in the Boston Sunday Globe, the Times of Israel, the Jewish Advocate, and the New York Times. 1 in 40's fieldwork suggests that most patients are unaware of their 1 in 40 risk because most PCPs are unaware of this 1 in 40 statistic. Compounding the problem is the fact that many PCPs are not familiar with the nuances of BRCA gene mutations. For instance, a lot of doctors don't know that half of people with a BRCA gene mutation have no known family history of the associated cancers. Many physicians don't know that men are equally as likely as women to both inherit a BRCA gene mutation and pass it on to their sons and daughters. Here's another very little-known fact about BRCA. Only one parent, the mother or the father, need be BRCA positive for each of their sons and daughters to have a 50% chance of being BRCA positive themselves. Dana-Farber's Jill Stauffer now serves on Oneinforty's medical advisory board. In that capacity, she prepared a literature review for us comprised of some of the many landmark studies that support population-based screening for Ashkenazi Jews. These include the 2014 Gabay Kapar Levi Lahad study, which showed that population-based screening would identify many carriers who are not evaluated by genetic testing based on family history criteria. The Manchanda-Jacobs study in 2015 used a decision analytic model to show that population-based screening would save more lives than family history-based screening and result in lifetime cost savings of 3.7 million pounds. Population-based screening would likely result in even higher lifetime cost savings today, as the cost of BRCA gene mutation testing has come down considerably in the past several years. Last year, the Manchanda-Legud study supported population-based testing for women who have anywhere from 1 to 4 Ashkenazi Jewish grandparents. So even just one Eastern European Jewish grandparent, and the risk of being BRCA positive is 1 in 40. This year, the Lieberman-Levy-Lahad study concluded that universal screening circumvents dependence on family disclosure, which at best is no higher than 50%. Landmark studies such as the ones I mentioned have shown that population-based screening, when compared to family history-based screening, results in no lasting undue psychiatric harm. Did I go the wrong way? There we go. No lasting undue psychiatric harm, that it makes economic sense. I could have found out my BRCA status with a $250 test. The PARP inhibitor that I take daily costs $180,000 a year. And I can't even imagine how much my chemo and surgery and mental health support has cost over the past 2 years. Population-based screening, most importantly, reduces BRCA cancer diagnoses and saves more lives. George Washington University's Milken Institute of Public Health explains, quote, understanding the difference between health equality and health equity is important to public health to ensure that resources are directed appropriately, as well as supporting the ongoing process of meeting people where they are. For these reasons, providing the same type and number of resources to all is not enough. I think we're all in agreement on that. In order to reduce the health disparities gap, the underlying issues and individual needs of underserved and vulnerable populations must be effectively addressed, end quote. There is clearly a gross inequality here, namely people with Ashkenazi Jewish ancestry are at least 10 times more likely than members of the general population to be BRCA positive. Today, Oneinforty is illuminating a glaring healthcare inequity related to this inequality. Namely, it is not standard of care to identify members of this high-risk population, inform them of their risk, educate them about how to manage their risk, and offer them ready, affordable access to emotional support, genetic counseling, and BRCA screening. Oneinforty respectfully implores NCCN to address this inequity by updating its hereditary/familial breast and ovarian cancer clinical practice guideline to recommend testing for the 3 BRCA founder gene mutations for all patients who have at least one Ashkenazi Jewish grandparent, regardless of known family history of the BRCA cancers. I speak today for all families in which a BRCA gene mutation is lurking. We are Oneinforty. Going forward, please meet us where we are, largely uninformed, underserved, often grief-stricken, and terrified to face our high risk of having hereditary cancer syndrome. Please help us find out our BRCA status before cancer strikes. Thank you for listening and for this tremendous opportunity to share our perspectives on how to prevent the B or CA cancers from developing, or at the very least detect them early when the patient's prognosis is best. I'll be at Oneinforty's exhibit table in the hall outside after the program. Let's talk.